So that's adenosine, a very important class for like or class 5, or you call it others in the other group, other drugs. A very important drug is adenosine, and it's the drug of choice for paroxysmal supraventricular tachycardia. That's PSVT. So adenosine, a short-acting agent, is a drug of choice for PSVT. This we are putting in others. That's one. Secondly, we are putting digitalis, digoxin. This is useful in cases of atrial fibrillation because you want to decrease the number of impulses going from the atrium to ventricle. So that's another agent, that's digitalis. And I'm also putting atropine in this particular group because again, it doesn't fit into 1, 2, 3 or 4. So I'm putting it in others, and atropine is useful for sinus bradycardia and for AV block. So that's our classification of antiarrhythmic agents. Class 1 sodium channel blockers, out of which the class 1A, they also prolong the phase 3 repolarization. Class 1B shorten the phase 3 repolarization, and class 1C no effect on phase 3 repolarization. Class 2 beta blockers, class 3 drugs which prolong the phase 3 or the repolarization due to the potassium exit, class 4 calcium channel blockers, and others. So let's move further. Further, we discuss the class 1A agents. These drugs prolong the action potential duration and increase the effective refractory period. Now have a look at this slide. What I've done on this slide is, the black curve is the normal curve, the normal phases of the action potential, and the blue one is the effect of class 1A. And if you remember what we spoke about class 1A is, it's a sodium channel blocker, so you expect the effects of the sodium channel blocker. In addition, this drug has got an effect of prolonging phase 3. So let's follow. Look at this. This is phase 0, that's the sodium entry. Now what class 1A has done is, it has inhibited this phase because it is a sodium channel blocker. So this phase is prolonged. Can you appreciate this? So this is the blue curve for class 1A agent. The phase 0 is prolonged, so it's happening little bit later. And if you look at the height of the curve is also decreasing. It's not reaching the same height as the original phase 0 or the phase 0 shown for normal action potential curve. So the height is also less. So you have showed your effect on sodium. The second thing you have to show about the sodium is the phase 4, because during the phase 4 there is slow sodium entry. So look at this, come to phase 4, this is a slow sodium entry, so phase 4 is also prolonged. So phase 0 is prolonged, phase 4 is prolonged. What's another effect of class 1A? Is going to prolong the phase 3. So we come here, we came up to this, that's phase 1, and this is phase 0, then this is phase 1, outward potassium current, and then you have the phase 2, that's the calcium entry. Look at the plateau. Now because this phase, the earlier phase got prolonged and the height of the curve also came down, that's why you see this decrease in the plateau. And then we come to the phase 3. Look at phase 3, follow the cursor. The phase 3 is prolonged. It means they also prolong the repolarization. I'm sure you understood this. This is class 1A. Let's go to class 1B. And what we had said in the beginning is, with the class 1 actions, is going to shorten the repolarization. So it's going to act on the phase 3, and the phase 3 is going to be shortened, and the action potential duration will be less. So let's have a look at the curve. Class 1B. Look at this effect due to the sodium channel. The height has decreased of the phase 2. The phase 2 is also prolonged. You can see this. So that's phase 0. Let's go to phase 4 because that's the sodium entry. The phase 4 is also prolonged. And the next effect is on phase 3. That's on the potassium, outward potassium current. That's the phase of repolarization. And what these agents do, they shorten the repolarization. So look at the phase 3, this particular curve for this drug, the dotted line has come inside. So I hope you appreciate this is the effect of class 1B. And when we say class 1B, we are speaking about lidocaine, a very important antiarrhythmic agent, especially in the post-myocardial infarction cardiac arrhythmias. So it shortens the repolarization. So that's class 1B. Now we go to the next slide, and the next slide is about the next group, and that's class 1C. So it's a classical sodium channel blocker. Is going to have those effects on phase 0 and phase 4. And what's the effect on phase 3? Look at the slide on the top. No effect on phase 3. So this is going to look like a classical sodium channel blocker. Effects will be shown only on phase 0 and only on phase 4. So let's follow the cursor. This is the deflection because phase 0 is prolonged. The height has come down because of the effect on phase 0. That's the sodium entry. And rest of the curve remains almost parallel to the original curve because there is no effect on phase 3. And we go to the phase 4. Look at phase 4. There is slow sodium entry. That's the phase 4. This will be prolonged because that's the effect of the sodium channel blockers. I hope you appreciated class 1B, 1A and 1C. Now we move on to class 3. We are not discussing the curves and the action potential phases for class 2 because class 2 are the beta blockers and they are going to affect all the phases. So we are not discussing class 2 agents, we are just discussing the class 3 agents. And if you remember class 3, what was the characteristic effect of the class 3? It's written on this slide, concentrate on the slide. On the top it's written prolong the phase 3. That's the repolarization. And who is responsible for this repolarization? Is the potassium exit. Let's look at the curve. Class 3 agents effect only on phase 3 and the phase 3 will be prolonged. So the black curve is the original curve and the red one is the class 3 agents. And look at the curve. It's going almost parallel because there's no effect on phase 0, 1 or 2, and from here you see the curve is going out, more outwards than the original black curve. So that's the prolongation of phase 3, or they're prolonging the repolarization and they inhibit the outward potassium current. That's the reason, and no effect on phase 4. So that's about class 3 agents. There's an interesting thing I want to share with. I have chosen red color for these particular drugs. It was not a coincidence. I am choosing red color because these are the drugs which prolong the repolarization and they inhibit the outward potassium current. And when this happens, if you think about the electrocardiogram, it leads to prolongation of QT interval. And this prolongation of QT interval is likely to produce arrhythmia. These class 3 agents are pro-arrhythmogenic agents and they can produce arrhythmia in the form of Torsade day point arrhythmia. And this is something dangerous about class 3 agents, and that was the reason for choosing this red color. I hope you are going to remember it, and I am going to repeat this issue. Let's go to the next slide, and that's class 4. Class 4 are calcium channel blockers. So they are going to act on two phases. Look at the slide written on the top. Prolong phase 2. Phase 2 is the plateau achieved by the calcium entry, and prolong phase 4. That's the slow calcium entry. That's the diastolic depolarization. These drugs decrease the conduction, they slow the conduction, and they increase the effective refractory period. So let's go to see the curve. There's a green color for the curve of the class 4 and the black curve is a normal curve. So this is phase 0, that's sodium entry, and after that there's phase 1, that's the potassium exit. And when you come to the phase 2, look at this phase 2. This black one, follow the cursor, I am showing is the original curve. So this was the plateau. Look at the height which was achieved in the normal curve. And here, these drugs are going to be calcium channel blockers. So you cannot achieve that particular plateau. So I hope you appreciate the plateau has come down due to the calcium blocker and is slowly getting prolonged. And the curve is getting deflected. And after this, you go ahead, there's no effect on the phase 3, and look at phase 4. This is the slow calcium entry, and the phase 4 is also getting prolonged. So effect on phase 2 and effect on phase 4, that's the class 4 agents. And I hope you remember the previous group, that's class 3 means phase 3. So this is how we could explore the normal curve for the action potential phases, and we try to overlap the normal curve with different kinds of agents which are acting on this action potential phases. So I think that was interesting. Now we further progress to discuss the antiarrhythmic agents. So sodium channel blockade, that's a very important issue. That's the class 1 agents, and it's called use dependent blockade, that there is increase more frequently the sodium channel opens, more will be the blockade. Are you getting it? It's use dependent blockade. If the sodium channel is open, it's available for use, there will be more blockade. This is very important characteristic of sodium channel blockers. They follow use dependent blockade, so they are useful to suppress the high rates. If the rate of the arrhythmia is very high, these drugs are going to act better. So that's called use dependent blockade. Class 1 are the sodium channel blockers. You can have a look at the table. Class 1A, we already said, it also has class 3 actions. It prolongs the phase 3. These are intermediate binding to the sodium channels. Quinidine, procainamide, disopyramide. Class 1B shortens the phase 3. This is additional effect. These are rapidly binding agents. This is lidocaine, mexilatin, tocainide, and phenytoin. Class 1C, classical effect of class 1, sodium channel blockade. No effect on phase 3, and these are slow binding agent, and you have a drug called flecainide in this group. Let's go to the next slide to discuss the class 1A agents. They are useful for supraventricular tachycardias as well as ventricular tachycardias. They are useful for symptomatic ventricular premature beats, VPB. They are useful for conversion of atrial fibrillation to normal sinus rhythm after blocking the AV conduction with digoxin, verapamil, or beta blockers. When you want to use a drug for conversion of atrial fibrillation to the normal sinus rhythm, you need to block the AV conduction. For this, you can use digoxin, verapamil, or beta blockers, and then you can give a class 1A agent. Please remember, class 1A also prolongs the phase 3, prolongs the QT interval, and can lead to Torsade de Pointes arrhythmias. So whatever I said about the phase 3 with the class 3 agents is they are prolonging the phase 3 and can lead to Torsade de Pointes arrhythmia. This is going to apply to all the agents who are prolonging the phase 3 or who are prolonging the QT interval. So that property of being arrhythmogenic will also apply to class 1A agents since they have just class 3 like additional effect. Look at the table. There are 3 drugs, quinidine, procainamide, and disopyramide. Quinidine has got additional alpha blocking effects and atropine-like effects, and it inhibits the renal clearance as well as the biliary clearance of digoxin, and it can precipitate digoxin toxicity. Quinidine, that's from cinchona, and actually the long-term use can lead to synchronism, nausea, vomiting, diarrhea, and the classical effects of synchronism. Plus, quinidine will decrease the blood pressure, hypotension, can lead to hypoglycemia, and it can precipitate heart failure. The second drug, procainamide, I remind you of genetic polymorphism. This is acetylated, and procainamide can have slow acetylators or fast acetylators. If they are slow acetylators, there will be SLE-like syndrome, and procainamide has got less GI toxicity. I remind you of the slow acetylators, SLE-like syndrome, some other drugs doing it. One is INH or isoniazide, and we discussed in hypertension, that was methyl dopa. So please remember, isoniazide, methyl dopa, procainamide, hydrolazine, all these can produce SLE-like syndrome. Procainamide also produces vasoconstriction. We go to the next drug, that's disopyramide, has got additional antimuscarinic or atropine-like effects, and you go to the last column to see what are these effects, atropine-like effects. So it's dryness of mouth, blurring of vision, retention of urine, and constipation. So that's the discussion about class 1A agents. They are sodium channel blockers, but important to remember, they also prolong the phase 3 and prolong the QT interval, so the patient will be prone to the Torsade de Pointes arrhythmia. We discussed the class 1A agents, and this is the table, the last table on the previous session. There's quinidine, procainamide, and disopyramide. Quinidine produces synchronism. For procainamide, there are slow acetylators and fast acetylators, and slow acetylators can have SLE-like syndrome. And disopyramide, important for antimuscarinic effects. Class 1A agents, in addition, have an effect of prolonging the phase 3, that's the repolarization. So class 1A agents are more susceptible to produce the Torsade de Pointes arrhythmia, just like the class 3 agents. I now take you to the next slide, and that's about class 1b. Class 1b is a very important class, and it contains lidocaine. This is useful for ventricular arrhythmias. Please remember, classical effect of class 1b will be ventricular arrhythmia, serious ventricular arrhythmia. It's useful for post-MI, that's post-myocardial infarction arrhythmia. It's useful for digoxin-induced ventricular tachyarrhythmias, useful for ventricular ectopics, and this drug lidocaine is selective for abnormal tissues. That's a great effect of lidocaine. Have a look at the table. The first drug is lidocaine. There are 2 or 3 things written below lidocaine which are very characteristic, and you need to remember them. Lidocaine even can act on the inactivated state of the sodium channel. It especially acts where there is damaged fibers or partially depolarized fibers, and all these things exist when there is a myocardial infarction, and myocardial infarction follows an arrhythmia. Lidocaine has high first pass metabolism. You can't give it by oral route. You have to give it by the intravenous route. And most important advantage of lidocaine is it doesn't have much negative ionotropic effect. So it doesn't have the myocardial suppression effect. So lidocaine is considered as the least cardiotoxic agents of the antiarrhythmic agents. If you give it in large doses, it can produce drowsiness, slurred speech, paresthesia, and convulsions. Now I said lidocaine has to be given intravenously. We have the congeners of lidocaine, mexilatine and tokenide. These can be used by oral route of administration, and their adverse effect is pulmonary fibrosis. We have another agent in this group, and that's phenytoin. And I hope you remember phenytoin is also an anti-epileptic agent, and phenytoin is a toxic drug. It's got low therapeutic index. So lidocaine for ventricular arrhythmia, ventricular ectopics, post-myocardial infarction arrhythmia, and digoxin-induced tachyarrhythmia. So that's class 1b, and it shortens the repolarization. We go to class 1c. We have flecainide here. It is useful in acute WPW syndrome, Wolff-Parkinson-White syndrome. The sodium channel blockade is there even at the normal heart rates, and it's more selective for the ventricular tissue. The rest of the 3 drugs, propafenone, morizecin, and enkenide, they act on all the tissues. These drugs, flecainide plus propafenone, morizecin, and enkenide, they have got a pro-arrhythmogenic effect. So they can lead to cardiac arrhythmia. However, they are useful for resistant arrhythmia and life-threatening arrhythmias, especially ventricular tachycardia and ventricular fibrillation, and sometimes for refractory supraventricular tachycardia, atrial fibrillation, and atrial flutter. So this group is not very commonly used because they are pro-arrhythmogenic, and they are used in selected cases for resistant and life-threatening, especially ventricular arrhythmias, and sometimes for refractory supraventricular arrhythmias. So that's class 1c. Now we go to the next group, that's class 2. And class 2 is beta blockers. They do prolong the phase 4, and they have got many effects. They decrease the automaticity, they decrease the AV conduction, they decrease the heart rate, and they decrease the contractility. I hope your autonomic nervous system is quite clear, and these drugs are the beta blockers. Propranolol is non-selective, and the cardioselective drugs are metoprolol, atenolol, bisoprolol, and you also have esmolol, which is ultra short acting. When you use a cardioselective drug, there is less risk of bronchospasm. Where do we use beta blockers? Please remember one thing. Beta blockers are potent myocardial suppressants. Don't think of ventricular arrhythmia. Beta blockers are mainly preferred for arrhythmia arising above the ventricle. So I'm calling it supraventricular tachycardias, atrial fibrillation and atrial flutter, and AV nodal reentrant tachycardias. What's the status of beta blockers in the management of arrhythmia? They are very useful. They are useful for emergency arrhythmia. They are useful for intraoperative, post-surgical, and post-myocardial infarction arrhythmias, and they are useful to treat arrhythmias during the cardiac procedures. And I have made this green color to remind you of esmolol, which is ultra short acting, which could be extremely useful in such situations. I take you to the next class, and that's class 3, and this is a much discussed class. Class 3, phase 3. I'm sure you're going to remember it. They prolong the phase 3 repolarization, so they inhibit the outward current of the potassium. That's the exit of potassium. Now we had said for class 1 agent that they had use dependence effect. Class 3 has reverse use dependence effect. So I hope you remember what was use dependence. More the heart rate, the drug is going to act better. More time the sodium channels open, the drug is going to act better. So this was class 1. This is reverse use dependent. There is a refractoriness which increases at lower rates, and there's better effect at lower rates. These drugs produce prolongation of action potential duration, and they are more efficacious in prevention of arrhythmias rather than treating the arrhythmias. And the characteristic thing which was said about class 3 is these drugs are arrhythmogenic, and they are likely to produce Torsade day point arrhythmia associated with prolongation of QT interval. So I've written class 3, prolong phase 3 repolarization, inhibit potassium exit. Let's discuss the drugs. And you see on the right side, and you see everything red, this whole of the column is telling you that these agents are toxic. We discussed the first agent, that's amiodurone. Amiodurone is very typical. Its half-life is very long. Very long is how much long? Is up to 103 days. 13 to 103 days, a very long half-life, is about 3 to 8 weeks. And what's the reason of the long half-life? The reason is this drug goes to various tissues, it's got a very wide tissue distribution, a large volume of distribution. So the drug doesn't get out of the body so easily. That's why you get a long half-life. Amiodurone has got additional effects. We said when we started this chapter, it can also block the calcium channels. It can also block the beta receptors. It's also got some sodium channel blocking effects. So we call amiodurone as a broad spectrum antiarrhythmic agent, and it's useful for refractory ventricular tachycardia and for ventricular flutter fibrillation. Dronedarone is another agent related to amiodurone, and there is no iodine in dronedarone. Obviously, amiodurone contains iodine. So I am not calling it amiodurone, I am calling it amiodurone. Always pronounce it like this, is going to help you to remember the iodine, amiodurone. Now once we say of iodine, we remember a certain adverse effect, a certain tissue inside the body, and this is what I start with for the adverse effects. Once you say iodine, you remember about thyroid. Yes, it gets deposited in various tissues, and one of them is thyroid. Look at the tissues in which it gets deposited: thyroid, cornea, lungs, skin, and liver. And if you have these 5 tissues, you get the 5 adverse effects of amiodurone: thyroid dysfunction, corneal deposits, pulmonary fibrosis due to accumulation in the lungs, skin reactions, and hepatotoxicity. So that's about the 5 important adverse effects of amiodurone, all related to accumulation in the tissues and the wide tissue distribution. Next, iodine intolerance is another issue. And don't forget, amiodurone is a myocardial suppressant, so it will lead to heart block, it can lead to heart failure, and it can produce bradycardia. Rarely, it can produce tremors, ataxia, and dizziness. Amiodurone should not be used in high doses. You know, it's a class 3 agent, and it's not used for Torsade day point arrhythmia, obviously because it's a class 3 agent. But if you consider all class 3 agents together, between them, amiodurone produces less Torsade day point arrhythmia, and it's a broad spectrum agent. The next agent on the list is sotalol, and I hope you remember sotalol appeared at 2 places. One place is class 2 because it's a beta blocker, and it also has got class 3 effects, and this is why sotalol is here in the class 3. Sotalol is useful to prevent the sudden death after myocardial infarction, sudden death due to the arrhythmia after myocardial infarction. It's useful for recurrent arrhythmias and is useful for sustained ventricular tachycardia and atrial fibrillation. But the last column says there is a susceptibility for Torsade de Pointes arrhythmia. The last row is about dofetilide, ibutilide and bretylium. They are rarely used to treat atrial fibrillation, especially refractory ventricular fibrillation also. And these drugs also will produce Torsade de Pointes arrhythmia. So in summary, class 3 contains a broad spectrum antiarrhythmic agent in the form of amiodarone, which has got many other actions including calcium blockade, beta blockade and some sodium channel blockade, has a long half-life, very wide tissue distribution, accumulation in various tissues, and that's why leading to thyroid dysfunction, corneal deposit, skin adverse effects, pulmonary fibrosis and hepatotoxicity, plus myocardial suppressant effects. But this is a broad spectrum antiarrhythmic agent, should not be used in high doses, should be used cautiously for refractory ventricular tachycardia and ventricular fibrillation, and has got least reliability of producing Torsade de Pointes arrhythmia as far as the comparison with its other colleagues in this class are concerned. So it's less producing Torsade de Pointes arrhythmia as compared to other class 3 agents. And the class 3 group also has sotalol and other agents. So that's class 3. Let's go to class 4. And these are calcium channel blockers. There is use dependence for the open channels and for the rapid rates. We already know this. There is verapamil and diltiazem. And once again, just like beta blockers, I have written in red color, don't use in ventricular tachycardia. These are myocardial suppressants. Think of them only for the atrium, and they are more selective. Their effect is better on the atrial tissue. So the supraventricular arrhythmias, that supraventricular tachycardia, atrial fibrillation, atrial flutter, these are the indications for verapamil and diltiazem. They are calcium channel blockers, so they produce hypotension. Verapamil, as you know, can produce constipation. That's very characteristic of verapamil. And diltiazem produces hepatotoxicity. We have to be cautious. These are calcium channel blockers. Don't use for ventricular tachycardia. Don't use in presence of heart failure because they themselves suppress the myocardium. And whenever there is depressed cardiac function, take care not to use a calcium channel blocker. So this is class 1, 2, 3, 4. And now we go to the others. Have a look at the slide. And as I said in the beginning, a very important agent, you can call it class 5 or you can call it in the other agents, is adenosine. What's the speciality of adenosine? It's got very rapid onset of action, very short duration of effect. Can you imagine? We spoke about amiodarone just now, saying that the half-life could go up to 100 days. And look at adenosine, that's opposite. Its half-life is less than 10 seconds. It's very rapidly acting and it's useful, extremely useful for acute supraventricular tachycardia and atrial fibrillation. I am sure you'll remember adenosine is a drug of choice for acute supraventricular tachycardia or PSVT, paroxysmal supraventricular tachycardia. How does it act? It acts on the A1 type G protein coupled adenosine receptor. It's adenosine, it acts on the adenosine receptor, which is A1 type G protein coupled receptor, and is associated with activation of the acetylcholine sensitive potassium channels. It produces hyperpolarization and is effective in the AV node, SA node and atria. And you use it by intravenous route, 6 to 12 milligrams, or it's also available in the form of ATP, that's 10 to 20 milligrams. Adverse effect is flushing and bronchospasm, but as you know, the half-life is very short. These adverse effects are also very short lasting. In the others, I am also including magnesium sulfate, which is useful for digitalis induced arrhythmia. For Torsade de Pointes arrhythmia, we were saying class 3 agents produce Torsade de Pointes. This you can treat with magnesium. Magnesium affects sodium potassium ATPase. It affects the sodium, calcium and potassium channels, and it is used by intravenous route of administration, 1 gram over a period of 20 minutes. Go to the next slide. In the others, as I already said, I am including atropine and digoxin. on one slide, and it will be beautiful to see this. Atropine increases AV conduction, digoxin decreases AV conduction. So that's opposite effect. Atropine increases AV conduction, so it's useful for sinus bradycardia, AV block, and digitalis induced bradyarrhythmia. And what digitalis induced bradyarrhythmia is produced, that digitalis is down immediately on the same slide. It decreases AV conduction, so it is going to be useful in the management of atrial fibrillation to decrease the number of impulses going from the atria to the ventricles. So these are some of the other agents, some important agents. Now let's have some word about Torsade point arrhythmia. We spoke a lot about in the adverse effects. It's prolongation of action potential of ventricular cells, and it manifests as a long QT interval, and it's mainly produced by the drugs with class 3 activity. That's inhibiting the outward potassium current in phase 3. And why it's important? Because it's a life-threatening arrhythmia. Which agents are likely to produce it? Class 1A, that's quinidine, procainamide, disopyramide, because they have additional class 3 action. Then class 3 itself, that's sotalol, ibutylide, bretylium, and dofetilide. And there are some other drugs which can produce Torsade point arrhythmia. Let me remind you of terfenadine, astemizole, and cisapride. Terfenadine, astemizole, and cisapride, and also macrolides. So these drugs have got the potential to inhibit the outward potassium current, so they can lead to Torsade point arrhythmia. Some additional agents are quinine, mefloquine, artemisinin, and halofantrine. All these are anti-malarial agents. Then amitriptyline and other tricyclic antidepressants, and thioridazine and risperidone, these are antipsychotic agents. All these can produce Torsade point arrhythmia. How to manage it? Acute Torsade point arrhythmia, cardiac pacing, magnesium, and isoprenaline. And correct the hypokalemia, because hypokalemia is responsible for this arrhythmia. Chronic Torsade point arrhythmia, beta blockers, and cardiac pacing. And a reminder to you, class 3 agents are known to produce this arrhythmia, and it's less common with amiodarone as compared to other class 3 agents. Now I take you to a table which is going to tell which arrhythmia in the left column and what's the management, what's the treatment in the right column. Let's start with ventricular, and I hope you remember, as soon as we say ventricular tachycardia, you should remember of class 1B, and that's lidocaine. So look at the right column, lidocaine, phenytoin, and sometimes amiodarone. But the first place is cardioversion. Before going for the drugs, the best treatment will be cardioversion. Next, supraventricular tachycardias, that's above the ventricle. And as soon as you say about supraventricular tachycardia, is going to be PSVT, or is going to be atrial flutter, atrial fibrillation, paroxysmal atrial tachycardia. And I told you about two agents which are best for supraventricular, and I also said never use for ventricular. Do you remember? Beta blockers and calcium channel blockers. So is it there on this column? Yes. Supraventricular tachycardia, beta blockers, and calcium channel blockers. And before them, now I am writing the name of adenosine, because that's the drug of choice for PSVT. In addition, in this group, you can write amiodarone, which is a broad spectrum antiarrhythmic agents. Next row is PSVT, because I have put it separate away from, once again separately, apart from the supraventricular tachycardia. That's paroxysmal supraventricular tachycardia or specific tachycardia. Drug of choice, adenosine. In addition to this, you can use a calcium channel blocker, obviously, and that's verapamil. Let's go down. That's atrial fibrillation. For atrial fibrillation, management of choice will be DC shock. Apart from this, you can use digoxin. This will decrease the number of impulses going to the ventricle. You can use beta blockers and calcium channel blockers because it is supraventricular. You can use amiodarone because it's broad spectrum. And in addition to this, you can use quinidine, adenosine, ibutylide, and dofetilide. So all these agents can be useful for atrial fibrillation. Next we go to sinus bradycardia, and AV block, and the drug of choice is atropine. I'm sure you're going to remember because we discussed digitalis toxicity in heart failure, and there we said digoxin decreases the AV conduction, decreases the heart rate, so you can have sinus bradycardia and you can have AV block. Drug of choice will be atropine because atropine increases AV conduction. Next, a special arrhythmia I have written separately because you need to remember it. It's very important in your practice. Digitalis induced arrhythmias, post-myocardial infarction arrhythmias, and ventricular ectopics. Whenever we said about this, especially the ventricular arrhythmias, we said drug of choice is lidocaine. Lastly, intraoperative arrhythmias and the arrhythmias in emergency situations, we have esmolol. So, this was the review of all the arrhythmias, and I'm sure what I had promised you is this complex chapter we are going to resolve, and I hope it will appear resolved in your mind as well. I'm sure you will do it well. Best of luck.